kind of شو اسمه review for pediatric neurology history and examination. هذه طبعا لا تغني عن انه it's just a guide for you to add on, and kind of a guide for you to reach يعني to get a proper يعني sense of history taking and examination in neurology, especially in pediatrics. So practice is a mainstay actually. Plus يعني the underlying knowledge and theory parts. So just to remind you about the nervous system, we divide the nervous system to peripheral nervous system and central nervous system. As you know, central nervous system composed of the brain and spinal cord, whereas peripheral nervous system we have a bunch of autonomic and somatic nerves. Those autonomics carries the sympathetic and parasympathetic functions. To also remind you about the embryology part of the central nervous system. If you remember from the previous lecture, we explained that the nervous system origin is actually from ectoderm. The neural plate formed and fold to form the neural tube, as you see here. During early weeks of intrauterine life, the neural plate, the top of the neural plate, give rise to 3 vesicles, which differentiate with time to give us different structure in the central nervous system. For example, the forebrain differentiate to, this is what we call prosencephalon. So prosencephalon or forebrain differentiate to telencephalon and diencephalon. And in turn, telencephalon give rise to cerebral hemispheres, and diencephalon involves the differentiation of thalamus, and then the midbrain differentiate into mesencephalon, which give rise to midbrain. Now posterior structures, brainstem and cerebellum and medulla, all differentiate, and their origin is from the hindbrain. That's just to give you an idea about the origin of the spinal cord and how it's differentiated. Of course, there is like a lot of folds and things that differentiate further to give us this beauty or the brain, like the complex brain, and this is like just a structure. There is a lot of secrets about in the function itself as well. So when the differentiation completed, we then have in the mature adult brain 4 different loops. All right. So we have a pair of frontal lobe, and then a parietal lobe. They're divided by what structure here? Important structure, guys.
Central sulcus.
Excellent, Faisal. Central sulcus. So let's divide the frontal from parietal lobe. And then we have a pair of occipital lobe, pair of temporal lobe, and I'm sure that you learned from your previous study about the function of each lobe. So what's the function of frontal lobe?
Motor functions.
Personality.
Excellent, Nawaf Faisal. So it's involved in motor function and also executive brain function. It's also involved in personality, as Nawaf mentioned. What about parietal lobe?
Sensation.
Excellent, Nawaf. Yeah, sensation, body orientation. It's also involved in reading. What about the temporal lobe?
أعتقد الهيرنج دكتور البرينكيز area.
Yeah, it has function of hearing, but also it's involved in memory, emotional function. So all are important here in temporal lobe. Occipital lobe, you all know the function of the occipital lobe involves the vision, color vision, and to a lesser extent eye movement as well. So the peripheral nervous system, we have 12 pairs of cranial nerves and 31 pairs of peripheral nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Now, what are the problems that you might face in pediatric neurology? And I think during your round in the hospital, I'm sure you have seen one of those problems. So seizure is very common presentation to hospital, and also seizure mimickers. So there is a seizure, true seizures, and then there is abnormal movement mimicking seizures, which is not seizure. Do you have an example for this, guys? Okay. So seizures. What is seizures, ya Shabab?
Involuntary movements.
Normal electrical activity in the brain.
Abnormal electric activity in the brain, which give rise to any signs of or symptoms. ممكن تكون motor, ممكن تكون non-motor, but it's a transient and repetitive. Okay, if it's transient and repetitive and unprovoked, this is an epilepsy. Okay, now you can imagine that any transient sign and symptoms, whether abnormal movement, motor movement, there is also a lot of other movements that kids can do, which is not seizures. Example for this. Example, ya Shabab.
Korea.
Excellent. Movement. Something related to movement. Korea. من اللي قال كوريا يا شباب؟
نواف.
Excellent, نواف. أنا شايف بس نواف وفيصل يشاركون. شباب بنحمسكم شوي. طيب. So see, Korea, other movement, text, in early infancy also there is a bunch of many other things related to non-epileptic movement, like shuddering attacks. And then many others. I don't want to bother you with them. But this is an example that we have seizure and we have something we're not sure, is it seizure or not. And then there's febrile seizures. And then I'm sure you've seen patients with major disabilities, cerebral palsies, developmental delay, abnormal head size and shape, macro or microcephaly, and then craniosynostosis. Hypotonia is also a common finding and sign or symptom entails patient with abnormal neurological exams. The Guillain-Barré is one of the peripheral demyelinating disease that's not uncommon. Usually follows a viral infection. And do you know Guillain-Barré's? Have you ever seen patients with Guillain-Barré's, guys?
وهو الدكتور يصير زي الباراليسيس ان السندنج باترن لين يصير ما انفولفمنت لللنجز.
Yes, excellent, Faisal. So ascending paralysis, but it's lower motor neuron, and then those patients usually have peripheral nerve problem. It's demyelination causing them to have weakness, ascending pattern, and then also pain. They have areflexia, weakness, localization is lower motor. Usually we treat them with immunotherapy, which whether IVIG or pulse steroids, and prognosis is quite good actually. SMA refers to spinal muscular atrophy. It's another disease of anterior horn cell. Patient will have progressive kind of weakness in early infancy. And we have actually many types of SMA, but the characteristic findings or characteristic things that it's progressive, it's entail weakness, child usually alerts, and usually those guys have tongue fasciculations. So this is the presentation of SMA. If you've seen one patient, you will never forget that their presentations. Ataxia is another thing that could localize to many things. Ataxia, we see ataxia with children with cerebellar abnormalities, inflammatory or neoplastic. And also we see ataxia with children with peripheral vestibular ataxia. I don't want to bother you, but those are with many neurological information, but those are quite common presentations that you need to know how kids with pediatric neurology problems presents. Now, history, it's not different from any other history in any other system. So you start with personal information, you draw your chief complaint, and then your history present illness as you've learned as a story. And then the past history is really important because it might have an implication to what current problem the patient has. And then, of course, in neurology, developmental history is very important. So I need to know the child developmentally, what's the developmental set of the child. So patient with seizure and developmental delay is different from patient with seizures only with developmental milestone normal. Also, family history is very important. We deal many times with kids who have, or families who have 2 or 3 kids with disabilities. So we need to fetch and learn more about what's going on. Are we dealing with genetic or versus acquired problem? And then perinatal history is very important. What's the importance of perinatal history, guys, here? Why we take perinatal history? يا شباب.
عشان يعني السبلمنتيشن دكتور.
ايش؟
عشان السبلمنتيشن اللي هي كانت تاخذها وقت الحمل.
Now, what do we mean, Nawaf, Faisal, by perinatal history? Perinatal history, it's prenatal, natal, and then postnatal, صح? What do you think if there is, let's say, patient A, pregnancy was normal, he was full term, and then delivered spontaneously. And the next day he was at home and grow well and nothing happened. Patient B, pregnancy was okay, but there was fetal distress, and then mom delivered at, let's say, 34 or 32 weeks gestation, and the baby delivered with poor weight. It's like, less than 2 kg, and admitted to the neonatal ICU, intubated for some times. He had a seizure first day of life. So the patient, which one you think he's prone for epilepsy, seizures, disability, developmental delay, hypotonia, spasticity? Which one, patient A or patient B?
Patient B.
Excellent. That's why we pay attention to perinatal history. So perinatal history, we need to know if there is any perinatal complication that might do something with what we see on the patient now. So that this is the importance of perinatal history. It explains sometimes acquired causes of developmental delay, hypotonia, seizures, epilepsy. Okay. So please, guys, never forget those things. So if we say risk factors for current problem, we mean past history, if there is something major in the past history, developmental history, if there is developmental delay, family history, if there is cases, similar cases in the family, perinatal history, if there is a complicated perinatal. So all those risk factors for neurological problems. Of course, social, nutritional, and allergy history to complete the loop of history is very important. We always, if there is problems, just like a thought process of what we are dealing with as neurologists, we try to categorize: are we dealing with a process that is hyperacute, acute, subacute, or chronic? Because this is make a difference when you deal with a patient with, let's say, a basic scenario. We have a patient who was well, and then all of a sudden he developed severe headache and drop level of consciousness, and then aphasia, inability to speak. So what things comes in your mind as now? What's the presentation? Is it acute, hyperacute, subacute?
Acute.
Yeah, acute, hyperacute. Actually, it's just now. With 5 minutes, 10 minutes ago. Okay. So what things comes in your mind? what process comes in your mind if we deal with hyperacute? Hyperacute usually two things. Think about two things. Either electrical activity like seizure, إذا وقفت ما وقفت، إذا كانت transient you're dealing with seizure, أو vascular event like what? Strokes. Excellent, so strokes. So yeah, and then the acute, all other things of like entails infection, electrolyte abnormalities, all other things. Subacute, also infectious, inflammatory can present subacute. Also neoplastic process can present this way. Chronic problems, all other problems related to some genetic disabilities that they present with a kind of chronic, either progressive or non-progressive. So with regression or without regression. So this is the kind of thought process how we think about problems entails neurology. So the course itself gives you a hint about the diagnosis or the disease process. And then are we dealing with something focal or generalized process? Is it progressive or static? It's very important. Okay. Example, let's say we have a patient who's 6 years of age, boy, with developmental delay, and with time, parent noted him having our onset of seizures at age of 5 years, and then at age of 6 years he lost gradually ability of walk, and then currently he's 7 years and lost also ability to sit, and he beside all other problems of deterioration in speech and cognitive function. So what things comes in your mind? A patient with developmental problem, like developmental problems, صح؟ أنا يا شباب ما نبغى diagnosis، بس أبغى thought process.
cerebral palsy.
Excellent. هذه الكلمة اللي أبغاها. عبد المجيد, cerebral palsy, it's not cerebral palsy anymore. Why يا شباب؟ أنا I meant عبد المجيد كويس. I meant this because I want you guys to differentiate between cerebral palsy and other developmental problems or developmental issues, diseases. So cerebral palsy, yes, I agree with you. Patient with cerebral palsy, they have motor disability, أحيانا entails cognitive, أحيانا seizures, لكنه it's a static disease. So yes, I don't expect them to deteriorate with time. Whereas if there is a progressive course of regression, think about alternative diagnosis than cerebral palsy. So we have a lot of other metabolic etiology, white matter diseases, leukodystrophies, mitochondrial diseases, and etc. A lot of other disease. So there is a disease process going on and causing the patient to deteriorate with time. Okay. And then, of course, what's the onset of the disease is very important to have. So those problems, if you answer those 4 questions, if I ask you to see consultation in neurology, I want you to answer those 4 questions for me. Okay. This is in the history present illness, of course. Okay. Now, neurologists love localization. So what do we mean by localization? Localization, we have signs and symptoms that we want to go back and localize where is the problem. So we have cerebral cortex, and then we have signs and symptoms of brain stem abnormalities or involvement, and then we have cerebellar involvement, and then we have whole lower limb loop, which starts from a anterior horn cells. So spinal cord, guys, is this is spinal cord, it's upper, but the anterior horn cells in the spinal cord, it's the start of lower motor neuron process. So problems of lower motor neuron anterior horn cells. Example, يا شباب, for anterior horn cell disease. We've mentioned 2 minutes, so 5 minutes ago.
Spinal muscular atrophy.
Excellent. Spinal muscular atrophy. The disease process is the degeneration of, it's genetic, autosomal recessive degeneration of the anterior horn cells in this place, cause disruption of signal to be transmitted to the muscle. Okay, that's why there is paralysis, kind of paralysis of all muscle, because it's the signal from the brain would not carry on, and the transmission get disrupted, causing weakness in the muscle. But the disease process is in here. And now there is also diseases of peripheral nerves, and then neuromuscular junctions, and then also diseases for muscles. So we take history and examination to find out where is the structure in the nervous system get involved more. Now, I don't want you to be bothered with those things. It's two important things to think about: signs of upper motor neuron and signs of lower motor neuron, which we will learn shortly. For seizures, it's very important to take history and approach the history this way. So pre-ictal, ictal, and post-ictal. So pre-ictal is very important. We are trying to find something we call aura. Okay. What was the situation before the seizure happens? The child was sitting or standing, or what was he doing? He's doing, and is there any aura or premonitory sign or symptoms that cause him to have seizures, or precipitating or provoking factor? And then the ictal, at the onset of the seizures, we need to pay attention to the first signs that happened with the seizure, and then how the seizure progressed. Presence of speech, awake or aware, level of consciousness is very important, because it's differentiate, we used to call them complex and partial seizures. Nowadays, we focal aware or focal unaware or generalized. Okay, we will learn all this in the lecture of the seizures or epilepsy lecture. And post-ictal symptoms is very important. So post-ictal, what happened post-ictal? شباب احنا وقفنا هنا عند الاكزامينيشن، نروح نصلي 5 minutes ونرجع.
تمام.
تمام.
يعطيكم العافية. الحين الساعة 3:32. 35 مناسب ولا نرجع 37؟ صوت واضح يا شباب؟
اي نعم واضح.
اي واضح.
طيب. Now examination. So again, examination, like any other system, we start with general examination related to neurology. So what are the general examination related to neurology, guys? أول حاجة, okay, when you see the patient, you observe his behavior, Of course, you need to know his vital signs and growth parameters, dysmorphology, if there's any dysmorphic features, and don't forget skin examinations. Skin examination. Okay, those are the, and also I would add two more things. It's abdominal examination for visceral megaly and spine examination. Okay, so those are the general examination related to neuro. One, vital signs growth parameters, higher mental alertness and observation about his, interaction, and then dysmorphology, visceromegaly, spine and skin. Okay, and then you get a sense about his mental status. Cognition, alertness, activities, also speech, okay, comprehension. It's very important to get a sense about the mental status exam. And then we examine cranial nerves, and then motor system, which entails also reflexes and coordination, and then sensory system and gait. Okay, so this is the sequence of examination that you need to carry on in a patient with for neuro exam. Now, those are the signs of upper motor neuron and lower motor neuron that you need to know. Weakness. We do see weakness in patient with upper motor, and also we do see weakness in patient with lower motor neurons. But there is a difference between them. So anyone, ya shabab, what's the difference between the weakness here and there? Which one more severe in terms of weakness?
Lower.
Excellent, Faisal. Lower is really profound weakness. Okay, you might find normal, appropriate, or here you might find patient with appropriate or slightly decreased power, but the power in lower motor neuron is very profound weakness. You see weakness and atrophy mainly with lower. We don't see atrophy in many of conditions related to upper motor neuron disease. Reflexes, you expect to see increased reflexes in upper motor neuron disease, decreased, diminished or areflexia in patients with lower motor neuron. Fasciculation, common with lower motor, to be more specific, with anterior horn cell disease. Okay, so it's in lower motor neuron, but we do see it more, and it's characteristic for patient with anterior horn cell disease. Tone, here again decreased, tone here is increased. Okay, so the tone, either spasticity or rigidity here. Okay, spasticity or rigidity. Okay, whereas here flaccidity, flaccid weakness. Okay, excessive response present and absent here. Present because you're dealing with upper motor. It's an upper motor neuron sign. Okay, so these you need to memorize those things to distinguish where is the problem. Here the problem in the brainstem or spinal cord, whereas here the problem is in the motor neuron, whether anterior horn cell, peripheral nerves, neuromuscular junction, or muscles. Okay, so here is a patient comes to you. You need to observe his behavior, the motor activity, how he interact, because in children you might deal with a kid who is cooperative, and you can carry the whole full neurology exam, but in many occasions we see kids with a really young age, and you can't like really provide a proper neurological exam. So you need to be smart enough to get the most from your patients. But you need to have a technique and experience to do that. So observation is really very important. With observation, you get a lot of informations about child neurological status. So how he interact, is there any speech problem? Is there any motor deficit while he plays? Is there any abnormality in his behavior, like hyper activity, hypo activity, sluggish interaction, poor eye-to-eye contacts, things like this. And then you assess his fontanelles. It's very important because fontanelles also give you a clue about what you are dealing with. Bulging fontanelles, we see bulging fontanelles with what example, Shabab? Patient with, let's say, irritability, large head, vomiting, projectile vomiting, and his fontanelles are bulged. So what do you expect?
Hydrocephalus.
Hydrocephalus, yes. Another patient with fever, irritability, and bulging fontanelles. So patient A, hydrocephalus. Patient B, now another presentation. He presented to you with fever, okay, 2 days fever, decrease in activity. He's, let's say, 1 year, okay, or 9 months, خلاص. Decrease activity, decrease feeding, drop in level of consciousness, and fever. You examined him, bulging fontanelles, and his activity is sluggish, and his awareness is impaired. So what you will be concerned about?
Meningitis.
Excellent. Meningitis infection. So CNS infection, meningitis, encephalitis, and etc. So fontanelles can also give you a clue about what you're dealing with. A skin exam is very important. You learned from the previous lecture about importance of skin exam in neurology, and we will see shortly examples. And then measurements. Measurements is very important. In pediatrics, we deal with growth and development, right? So growth is by measurements, okay? Also, measurements entails head circumference, head size. So measurements, there is 3 things to measure: weight, length or height, and head circumference. Head circumference in neurology is very, 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 very important. It gives you a clue about what you're dealing with, because the development of the brain happens the first 2 years, okay, in life. So is there any apparition in neuronal developments or in any disease involve the brain? It could manifest by the size or the shape. Examples, Shabab, examples like what we have learned. Hydrocephalus gives you macrocephaly, right? leukodystrophies, a lot of other leukodystrophy gives you macrocephaly. A lot of genetic metabolic disease gives you microcephaly, and so on and so forth. So a head circumference is very important. Okay, and then mental status examination. So mental status examination is done mainly by observation. So you observe how their attention and how is their visual tracking, are they following? So an infant and young children, so all what you need to just see, are they attentive, are they following, smiling, interacting with you? Okay, if there is simple commands, are they following that? And then older children, you need to do more or different, whether to do a proper, questions-based evaluation to know their orientation, attention, language, and comprehension. Okay, what do you mean by comprehension, Shabab? So when we assess the language, okay, the language, it's either language, Shabab, language assessment.
comprehension اللي هو يكون إنه فاهم وش معنى الكلمة، فاهم وش قاعد يقول.
Yes, so this is one of the language assessment. Language is either receptive or expressive. Now, receptive is by comprehension. If you understand what you're saying, this is receptive language. Okay, expressive, it's by he is able to speak. And then in older also kids, you assess also repetition, naming as part of language examination. But I don't want to bother you with all those things. All you need to know, am I dealing with a child who's oriented, attentive, following, tracking with normal language? Okay. What is this, Shabab? This is a child who present to you with history of learning disabilities. What do you see?
والله صراحة دكتور ناسي اسمه، بس هذه مو اللي تجي مع تيوبروسكليروزز كانها أكن.
Excellent, Faisal. This is sebaceous adenoma. Okay, this is one of the features of tuberous sclerosis. So by just examining the skin, you'll find that this patient have skin lesions that is suspicious for a neurocutaneous disease. This is what all you need. Okay. Okay. Another patient present to you with seizures. So he has first seizure in life, and you examined him, you find those spots.
Cafe LA spot.
Excellent. So those are cafe LA spots, suspicious for what disease?
Neurofibromatosis.
Excellent, neurofibromatosis. Okay, what is this?
Port wine stain.
شباب ما في إلا نواف وفيصل وعبد المجيد أحيانا. We need more participants يا شباب. This is what يا نواف معلش؟
Port wine stain.
Port wine stain. Yeah, excellent. Sturge-Weber disease. Okay. So, okay. And then this is just to show you what's the importance of skin examinations in neurology. Okay. And then we will focus more today on cranial nerve exams. Cranial nerve examination, if the child is cooperative, you can conduct this formally. If the child is non-cooperative or you're dealing with young children's, observation is the mainstay. So you observe the spontaneous activity, the quality of his cry, the symmetry of his face, the symmetry while he's grimacing his face, the eye movement. You try to play with him, you try to bring things and then to see his follow and extraocular eye movement, and also response to light. We don't usually do this visual threats, but this is if you want to assess corneal reflex. You assess roughly the visual fields. You try to distract him and then distract him with another a toy from peripheral vision and see how he responds to that. So all those like give you a clue about, and of course, if you're for muscles of mastications and for the cranial nerve 5, also glossopharyngeal nerve, and so cranial nerve 5, 9, 10, and 12 also can be assisted by just observation, observing that the child is able to suck and swallow without any issues. Okay. Now, to remind you about cranial nerves, they are 12 and their functions. Smells conducted by olfactory, visions by optic, and they are pure sensory nerves. Eye movement by the 3rd, 4th, and 6th. And then the trigeminal nerve conduct facial sensation and responsible for supplying muscles of mastications. Facial is very important nerve and usually comes in many OSCE exams. It's both sensory and motor. It's responsible for facial expression and anterior 2/3 of the tongue taste. Vestibulo-ocular, from the name, is responsible for hearing and balance. Glossopharyngeal also play a role in taste and gag reflex and sensory and motor function of the pharynx. As well also the vagus nerve. Accessory, spine accessory, it supplies the trapezius muscle and also supplies the sternocleidomastoid. So it has to do with the neck movement also and shoulder shrugging movement. Hypoglossal nerve supplies the tongue. So it's important in swallowing and speech. If you pay attention here, there is 1, 2, 3 only pure sensory nerves, which is olfactory, optic, and vestibulocochlear. And there is how many? 1, 2, 3, 4, 5. So motor, mainly motor, and there is trigeminal and facial, trigeminal, facial, glossopharyngeal, vagus conduct both sensory and motor functions. Now, we don't routinely test for olfactory cranial nerve unless if there is, a suspicion of function loss, like anosmia. Okay. We test this way, that you bring a common odor and you ask the child or the patient to close his eyes, trying to identify this odor. Again, this is not routinely tested unless it's needed. Optic nerve carries function in visual acuity, color vision, visual field, pupillary reflex, and fundoscopy. Okay, so visual acuity formally done by Snellen chart. If the child is uncooperative or the child is young, you can bring small things and or any small objects or like small scratch in a paper and try to see if he is able to see those ones. If he's cooperative, enough, you can ask him to read a paragraph or read a sentence to assess his visual acuity, but formally done by Snellen chart. This is Ishihara test, okay, which tests for color vision in cooperative patients. And then the visual field done by this way, okay? So you sit in the front of the child. So let's divide children to two types. So children who's cooperative and children who's non-cooperative. So in cooperative children, you will sit the same way here in front of the child, and you spread away your fingers and ask the child to point to the finger that's wiggle, okay? And see if they have in four quadrants, in all four quadrants, then 2 up and 2 down, okay? And in younger children, all what you need to do is to try to let them focus with, let's say, their parents, and then you try to bring a toy or any attractive colored toy to his peripheral vision to see if he's able to catch that up or notice that. Now, pupillary reflex, you shine. We have direct pupillary reflex and we have consensual one. Direct pupillary reflex that you shine a light in the patient eye and see if he's able to constrict his pupil. Usually, the constriction happens for the same eye, and also the contralateral one will get also pupillary constriction. So what cranial nerve you are testing by pupillary reflex, guys?
oculomotor.
عبد الله يعني صحيح بس part من الإجابة. So there is an afferent and there is the efferent. Afferent, we are in the optic nerve, صح? So pupillary reflex is related, يعني assist the integrity of optic nerve. Also the integrity of the third nerve, oculomotor. Okay, so the afferent goes by the optic and the efferent, which is pupillary restriction, mediated by the third cranial nerve. Okay. Now the extraocular eye movement. When you do this, you are testing 3 nerves: the third, fourth, and sixth cranial nerve. So you ask the child to follow your finger by only his eyes. So his head is stable and his eyes are moving. And then you move to the right and then to the left. Assess if there is any nystagmus, if there is any movement pulses. Okay, and then also up and move down and then move to the side corner and to the side corner the other way, and then the other way is out in an X shape. Okay, and trying to figure out if there is any gaze pulses, if there is any diplopia, if there is any nystagmus. Okay, so this is a child that you see in primary position. Okay, he's having what he's having. Shabab?
Proptosis in the left eye.
Ptosis, actually, ptosis in the left eye, which is good pickup. So he's unable to open his eye, his left eye, and also the left eye is pushed lateral and downward, so outward and downward with ptosis. So this is a palsy in the left third cranial nerve. Okay, so third cranial nerve, you will find the ptosis component. You'll find a primary position of the eye in the inward and outward direction, and he's unable to move to the other way. So if you do you test the movement, the child can abduct his right eye to the right and cannot abduct the left eye. Okay. Now I want to move in the 9 minutes remaining. This is a patient who's in what's the problem here? So this is the primary position. In the primary position, okay, this is central. This is pushed away, okay, and then you ask him to move to. You moved your finger to the right, able to adduct. But when you ask him to move to the left, he's able to adduct the right eye, but unable to abduct the left eye. So there is a problem here in the lateral rectus muscle, which is supplied by sixth cranial nerve. So there is left sixth cranial nerve palsy. Okay, this table, show you a characterization of the third cranial nerve palsies that you might see in neurology. Now, trigeminal nerve is tested by, it's divided to 3 branches, ophthalmic and maxillary and then mandibular. Those branches carry sensation of the face, and also the so you test for this by cotton or any piece. Ideally, it should be conducted by dull and sharp object, and you ask him to close his eye, and then you touch here, for example, you ask him to identify what's the sensation, is it sharp or dull, and the other way around. So you see symmetry, you assess symmetry, and also you assess fine touch. And in all 3, so you assess one here, one there, one here, one there, one here, one there, one here, one there, like this. This is assessment of the sensation, and then the assessment of motor function. You assess the temporalis for atrophy and for movement and power, and you assess here the tragoid muscle. You ask him to open the jaw, and see, and then you ask him to open the jaw and move it to the right for and against resistance, and move it to the left against resistance. This is an assessment, a formal assessment of the power of those muscles of mastications. And then the facial nerve is very important. It's just, you assess the child by, examining facial asymmetry. So there's clear facial asymmetry without examining the patient, but you examine him this way. You ask him to raise his eyebrow, okay, to see if there is a wrinkles in the forehead or not, and you ask him to frown to assess his facial grimacing. So when he frown, there is palsy of this side, okay, Ask him to close his eyes tightly. So you'll be able to close this one and you'll not be able to close the other one. To pair his teeth, this will emphasize more, to smile again and to puff the cheeks. So this all techniques that lead you to diagnosis of facial palsy, for example. So here we have this patient with bright facial palsy. Okay, bright facial palsy, but if it's just the lower face, for example, he's able to close his eyes symmetrically here, I'll be worried. Okay, because I'm dealing with, if the lower face only involved unilateral lower face, I'll be dealing with upper motor neuron lesion. Okay, if there is a whole lateral face, whole hemi face involved, like eye is involved and also lower face involved, I will not be worried. Why, guys? Now, lower motor neuron and upper motor neuron. Lower motor neuron, something we call Bill's palsy. Upper motor neuron, you might be dealing with any brainstem lesion, tumors, inflammatory, infectious, anything in the brain. So if you find a patient with lower motor neuron, means all upper and lower involved, you don't need to do neuroimaging. If there is a patient with eye spared and just lower face involved, you need to do neuroimaging to rule out intracranial process. Is that clear, Shabab?
كثير.
ايوه كلير دكتور.
Okay, and then vestibulocochlear nerve, again by Weber and Rene test. Weber to see if there is any lateralization, Rene to differentiate between conductive and air conductive. So if there is no lateralization from Weber, that's normal. If there is lateralization, for example, to this ear, okay. Now we conduct. If there is lateralization to this ear, either we are dealing with conductive hearing loss in this one, or this one is normal and there is sensory neural hearing loss in the other one. Okay. To differentiate, you do a Rene test to be able to differentiate if there is conductive loss or normal ear. So if there is conductive loss, the bone conduction will be higher than the air conduction, which is normally the air conduction higher than the bone conduction. Okay. Glossopharyngeal nerve, you inspect the mouth and ask him to open the mouth to see uvula in central position, and ask him to say ah to see if the palate and uvula elevation. Gag reflex, we do it in patient who's comatose. We don't routinely do it in patients. So the movement of the palate is give you a hint about those two nerves. Glossopharyngeal, spinal accessory is this. So you assess shoulder shrugging, you assess the movement of neck against resistance to the left and then to the right. Hypoglossal, you ask him to protrude his tongue. You see if the tongue is deviated or not. So what is the problem here, left or right, Shabab?
المشكلة left.
Problem is in here, okay, the right one, because it's the muscle is pushing, and now there is palsy. It's not pushing anymore. So the dominant side, the right side, dominate and push the disease side. So those are the القاعدة هنا, lesions of the 5th and 12th deviation toward the disease side, and lesion in the 7th and 9th deviation to undiseased side. Motor exam. شباب تبون نطلع مرة ثانية؟ باقي لنا شوي، نطلع ندخل ولا كيف أموركم تبون تخلصون؟ لأنه أنا أقدر أخلصكم دقيقتين. والله ما نقدر نخلص دقيقتين. أباخذ منكم 10 دقائق مور، تسمحوا لي؟
مو مشكلة.
تمام.
طيب ندخل ونطلع وندخل. آسف. أوكي. ناو الصوت واضح يا شباب؟
اي نعم واضح.
ايوه.
Okay. Now, after we've tested the cranial nerves, just to go back, general examination related to neurology, you assess the mental status of the child, and then you conducted the cranial nerve examination. What next? Next is motor examination. Now, again, as any other part of neurology exam, start with inspection. So inspect for what? Inspect for the muscles. So look for the muscles of the child. Okay, look for the position of the sitting, how he's sitting. Is he sitting in C shape or normal, bulk? Normal tone. Child with hypotonia from position, you observe them like hypotonic. يعني حتى هو جالس تحسه جالس C shape كذا. So this is for inspection. Now this is for tone. Like for bulk, you assess the atrophy and the muscles. Bulk is reduced. Okay. If you see patients with atrophy and reduced muscle bulk, you will always remember this. And you inspect for the tone, as we've mentioned. The tone inspection, كيف هو جالس؟ تحسه flexible ولا؟ And then you assess for the muscle strength. Okay, احنا شفنا البلك، شفنا التون by just inspection, and then we assess the tone. Assess the tone. Okay, how we assess the tone يا شباب؟ It's movement against activity, so passive resistance. So you feel resistance against passive movement. So you move the child, تمسكه تسلم عليه وتقعد تحرك يده. Okay, with time you will build up experience about the tone. If there is resistance, tone will be normal. If there is no resistance, تحسه كذا ما في resistance. حتى هو جالس أساسا تحسه كذا جالس C shape. When you move the muscles, there is no resistance. This is reduced tone. Okay. When there is resistance, تحرك اليد في spasticity or rigidity. This is increased tone. Okay. Now, after we assess the tone, احنا البلك عشان نقول والله normal ولا reduced bulk. Okay. التون عشان نقول normal, reduced ولا increased. Okay, because increased is with upper motor neuron, reduced with lower motor neuron, normal with normal, right? And then you assess the strength. Strength اللي هي الباور يا شباب. الباور في grading system. فالشولدر you ask him to abduct his shoulder and push against resistance. Elbow you ask him to flex his elbow, okay, and try to open his hand against resistance. And try to ask him to push to see to assist flexor and extensors of the elbows, and then to assist flexor and extensor of wrist and hand grip, and then the assessment of hip flexion, hip extension, abduction and adduction. And the knees, you assess the knees, knee flexion, knee extension. Ankle the same way, plantar flexion, okay, dorsiflexion, eversion and inversion. So you assess all those and you apply the power that you get to a grading system. 0, there's no movement. 1, there's flickering of movement. 2, there is movement with gravity. 3, grade 3, there's like movement against gravity, but there is weakness. Okay, and there is 4, grade 4, he's weak, but he's able to provide movement against some resistance. Normal muscle strength, the child resists you normally. So if you examine kids' power more, you will get sense of those of weakness. Okay. And then sensory testing, you test both distal, lower, and upper extremities. You test for cortical sensations, deep sensations. You test deep sensation test by tuning fork for proprioceptions. Okay, I'm sure you did this in medicine and elsewhere in family medicine, and you read it. You need to just practice and know also the theory parts. We have cortical sensations, we have superficial, and we have deep sensations. Superficial sensations entails sharp, dull, and temperature. Deep sensations involved proprioceptions. Okay. And proprioceptions and also cortical sensations. Cortical sensations, there's something called 2-point discrimination testing, and there's something called agraphia. Do you know those things, ya shabab? For cortical sensations, ya shabab, assess. You ask the child يعني تمسك اليد وتكتب فيها. This is 1. What's this number? تكتب number 2. But you try to see if he's able to predict the number that you've written ولا لا. Okay. And also 2-point discrimination. You bring 2 points close, and you see, is he able to differentiate 2 points in his hands or not? Okay. We don't routinely do sensory testing in uncooperative child. So for sensory testing, actually you need cooperative child. Okay. And then the deep tender reflexes, it's very important to test for biceps reflex, and then brachioradialis, and then triceps in the upper, and then patellar reflex, which is in here, Achilles tendon reflex, and get the sense of the deep tender reflexes. So if there is no reflexes, this is 0. If there's hyporeflexes, is +1. +2 is normal reflexes. Hyperactive or brisk reflexes, and +3, and further +4 there is an clonus. +5 sustained clonus. So what I need you to know is that is the reflexes present or absent? Okay, so if it's present, is it hypo, normal, or hyper? Okay, hyper +3. Okay, +4. +4 is with clonus. Forget about +5. Okay. Now, how you test? You tap directly on the tendon and assess the muscle movement or action. Okay. So did you do that يا شباب في البراكتس؟
ما ادري اذا بعض الشباب سووها على ريل بيشنت، بس كنت سويناها between us يعني في الكلينيكال سيشن في البري كلينيكال.
Yeah, you need to practice عليها. This needs practice actually. Okay, you need to حتى when you tap in gentle way. الموفمنت تكون من الريست، ما تكون مثلا الموفمنت في اليد كلها كاملة. يدك لما تضرب على التندن نفسه تضرب جنتلي، ولما تضرب برسايز كذا، حركة دقيقة، والحركة تكون من الريست. اوكي. طيب, this is Babinski sign. This is positive extensive response. This is negative response. This is the signs of upper motor neuron. Okay, when you scratch the lateral border, there'll be extensive response to the big toe and fanning of the other toes. Now, coordination is very important and very easy to examine. So you assess the upper limbs by doing finger to nose testing and observe if there is any intention tremors, how smooth the movement is. And then for lower, you do heel to shin testing and observe for smoothness of the movement. This is the heel and this is the shin. You ask the patient to slide his heel against the shin and see if he's able to do that or not. And then there is something called rapid alternating movement. What is that, Shabab, rapid alternating movement? This is to test for something we call dysdiadokinesia. Dysdiadokinesia is a sign for cerebellar ataxia, okay? So coordination problem, cerebellar problem, there'll be dysmetria, intention tremors with finger to nose. There'll be also dysmetria with heel to shin, and there'll be dysdiadokinesia, okay, which is تعرفون حركة اللي هو اوكي يضرب على الطاولة مثلا او يضرب على فخذه اوكي بيده ثم يضرب على الدورسم ثم يضرب على البالم ثم يضرب على الدورسم زي الخباز اوكي او يخبز على يده اوكي and see if he's able to do that repetitively without any difficulties او قاعد يحوس فيها. واضح؟ So if إذا ما كانت smooth, this is يعني dysdiadokinesia. إذا كانت smooth, this is normal rapid alternating movement. clear ولا ما هي clear؟ عموما هذه تحتاج يعني سيشن نيورولوجي وتشوفون كيف الطريقة قدامكم. لكنه do you know what I'm talking about now ولا لا شباب؟
ايوه دكتور واضح.
وش كيف اشرح لي انت عشان اتاكد انه واضح. اي واحد يا شباب يشرح لي.
اللي هو ان الدكتور ياخذ الكعب حق رجله ويمشيه على الشن.
Okay, this is for heel to shin. What about rapid alternating movement?
اللي هو ان اذا ما كنت غلطان ان هذه اللي يرفع يده ويحطها على دورس من الهاند بعدين ينزل يده اليمين ويرفع يده اليسار ويحطها على دورس من الهاند ويسوي alternating بسرعه.
تعرف حركه التصفيق؟ صفق بيدك، هذه صفقه صح؟ خليك معي فيصل.
اي سمسم دكتور.
هذه صفقه، سمعت الصفقه؟
ايوه.
طيب اصفق نفس الصفقه بس حرك اليمين حطها الدورسل. شوف؟
اي فهمت دكتور. انه يعني يصفق اول شيء بالبالم بعدين الدورسل بعدين بالم بعدين
الدورسل. ايوه ويبدا يسويها شوف كذا ها. واضح؟
يس.
هذه سموث. اوكي اللي عنده مشكله يبدا يسوي لك كذا. يخبص ما عرفت اقصد ما يقدر يضبطها. ذا سيم واي تسويها في الليفت. تصفق بال تصفق دورسل بال دورسل بال دورسل زي كذا عرفت؟ فذس از تقدر تسويها برضو على الطاوله مثلا بهالطريقه هذه بال دورسل وهكذا. اتمنى انها تكون واضحه. عموما شوف فيديو لها. And then we have Romberg's test. Romberg's test for integrity of وش يا شباب peripheral nerves. إذا كان فيه problem في peripheral nerves Romberg's test حيكون positive. واضح؟ كيف إيش نقصد في Romberg's test? Romberg's test you ask the child to bring his يعني يكون standing واقف bring his feet together okay and then you ask him to close his eyes. Normally he'll be يعني stable Romberg's test, when he closes his eyes, he'll be falling. He'll fall. فلازم تكون supporting them him. لأنه ممكن يطيح إذا كانت positive. Okay. And then the gate, of course, we have يعني gate is very important to assist the integrity of motor system. Okay. If there is a weakness, if there is this coordination, so if there is ataxia, حتشوف wide-based gait, wide-based incoordinated gait. إذا كان فيه weakness حتشوف depends. إذا كان والله hemiplegia حتشوف hemiplegic weakness. إذا كان فيه spasticity, hemiplegic spasticity, hemiplegic gait. Spasticity with diplegia حتشوف اللي هو spastic gait. إذا كان فيه lower motor neuron disease أو peripheral nerves حتشوف مثلا foot drop في الجيت. إذا كان فيه proximal muscle weakness حتشوف gait زي ال waddling gait، حاجة نسميها waddling gait. اوكي waddling gait تحسه كأنه يمشي. لازم تشوفون فيديوز عليها يا شباب. فالجيت gives you a lot of information about what you are dealing with in your patient. يعطيكم العافية. I know this is يعني ممكن تكون نيورو بطبيعته ثقيل شوي، خاصة الإكزامينيشن. لكن الإكزامينيشن I meant to bring those ones for you to be able إنه أوكي سمعتها مني الآن، بتروح الميديسن تسمعها، بتروح لأي مكان تسمعها، وبتبدأ إيش تتعلمها with time with practice. النيورو من أصعب الإكزامينيشنز اللي ممكن تمر عادة. في الأوسكيز اللي examination يعني مثلا في الابدومينال examination cardiac examination special examination تجي ممكن كستيشن كاملة. نيورولوجي no way إنه أحد يجيب النيورولوجي كأوسكي the whole neurology exam. So you will find مثلا parts من neurology exam. Examples cranial nerves أو مثلا sensory exam أو مثلا motor exam أو مثلا coordination exam. أوكي هذه اللي تجيك مقطعة كذا في الأوسكي. So go back, read the theory part, try to practice this week on patients for neuro exam, and this is the way how you learn that. Okay. Questions. معليش أنا عارف إنه ممكن وقت ما هو مناسب، الحضور ضعيف جدا، بس اللي حريص وحضر feel free to ask. طيب يعطيكم العافية يا شباب.
الله يعطيك العافية دكتور، شكرا.